Well, good morning or good afternoon, everybody. So we are actually on the session for the topic 18, which is we're going to be learning today about IMRT treatment planning and what is a good plan. And I'm Cesar Della Biancia. We met the last two sessions. The previous sessions we talked about contourings, and the previous session we talk about more of the details of the optimization with IMRT. So now we're going to see how by implementing that and the method we describe for optimization, how can we evaluate a plan and how can we be confident to say, okay, is this the best plan that I can do? Can I do better? Can I do worse? Hopefully not, but that's basically what we're going to be talking today. As any other of the lectures, so if you have any questions, just write it in the chat. And then we can go at the end. Then I'm going to pause in between and see if anyone has questions in between, but we'll address them all at the end of the presentation. So this is going to be the outline of this talk. We're going to talk about what is a good plan. Then we're going to go through like the general evaluation criteria. What are things that we need to think, that we need to know when we do a plan, about target coverage, about ORs, those evaluation criteria. We're gonna stop a little more in the optimization progress, but more not just the details of how to optimize, because we did that last session. This is more how to, how do you know when you push something hard or no? Is this the best I can do? And then at the end, I'm gonna give you a couple of examples of plans, finalized plans that hopefully they are good plans too. So starting with what is a good plan, as always, and I think this applies to everything in our professional life and also in life in general, experience is gold. So basically, you can have a lot of knowledge. You have read a lot of books. You can take courses and everything, but hands-on is what it gives you the experience to determine if a plan is the best that you can do, and that's in general for any other process. So the more you practice, the better you get in basically evaluating a plan and making sure that you make the right decisions. I came across this question, and actually I found it in a book that the question is, what makes a good treatment plan? And I thought it was good, but this is a very general answer. So, and it's a very actually technical answer. So basically in this book, they said, what is a good treatment plan? The best plan maximizes the tumor control probability while balancing it with normal tissue complications probability. So basically a good plan is that you cover the tumor as much as you can, so to control the tumor control probability, and while minimizing the dose to the ORs. That's basically the goal. But that's a very general definition, which is good. That's the goal, but actually there's a few parts in between. To make these, actually there have been many theoretical models that have been developed for these quantities, the TCP and the NTCP, based on biological models of cell killing and Poisson statistics. So this is basically the mathematics of it. But we need to go further and ask ourselves, okay, yes, a plan that meets the target coverage and the ORs, those evaluation criteria, is a good plan. So just with that, I mean, do you think that's a good plan just because you met the target coverage of our evaluation? We can say yes. We can say no. And I wonder if we can say yes, but it is not enough, because it is kind of, yes, of course, this is the most important thing. I mean, I would say yes, it is a good plan, but it's not always enough, because you need to start asking yourself a lot of other questions that can make a plan perfect, if you may. So, for example, have you pushed enough to get the lowest possible dose to ORs with the ALARA criteria, as low as reasonable, achievable, and the best target coverage possible? So basically, yes, I met all the constraints, but can I do better? Can I decrease the dose to certain ORs? Or can I improve the coverage a little more? So again, so you met the constraint, you met the target coverage, but did I do a good job to make it as low as possible, especially for the ORs? Also, you need to keep in mind that, as we saw in the previous presentations, inverse planning, which is used for IMRT and BMAT, can spill those in not desirable places, because you're constraining so many things, so the dose needs to go somewhere. So you need to be careful while you're meeting this constraint, where the dose goes actually, or what is the sacrifice that you need to take because of your limiting the dose to certain ORs. So it's very important to carefully inspect the isodose lines. Of course, the high isodose is the prescription and the hotspot, but also the low dose. You need to make sure how the rest of the body, what's happening in the rest of the body beyond the extension of the PTV. And most of the modern treatment planning systems have the capability to review distributions in the different planes. So in the axial planes, and you can toggle coronal and sagittal. That's something that most of the treatment planning have that possibility, but years ago, it was not that easy. So you needed to use different techniques to make sure you didn't have weird distributions somewhere else in the body. But now we do have that capability, so we need to take advantage of that. So as also, like we talked about this before in the topic 16, every plan is started with the good, remember that we said, with good contours and the optimization structures only. These are very important structures that if we don't do a good job with the contouring, we're going to be confusing the optimization algorithm. And then it's going to be, maybe you have some contradictory constraints or things that they don't make sense. So that's why it's very important to start with good contours. Especially you need to pay attention to these optimization only structures that we create to help the optimizer. So, and I say help, so we want to help the optimizing, not confuse it. So that's what, here are some examples of the contours that we went through and we created to help us optimize the plans, like the max PTVs or the rings. You can remember that we said you only need one ring, but you can also create extras, like in this prostate case. So we're not going to go through that, but remember that good contours lead to good plans. Also, the beam arrangement is very important. So because, IMRT is a little more permissible, let's say. If you have just any beam arrangement, most probably the algorithm will give you a decent plan. Even it doesn't matter. For example, in the plan below, in the example below, that we have a lung case and it's on the right side. So you could have used the beam arrangement on the left, which is these 6 fields distributed around the body. And also, or you can use the one on the right. So which one do you think that it will be the best, or the most efficient, let's say, for the system? Both are okay, and I'm sure both are going to give you a good plan. But do you think that you can actually do better because you choose something else? I guess maybe, this is a question we can ask in the chat. Just put yes on left or right. Which one is the one that you will choose, for example? And I'm going to try to see the chat, which I can't, but.
Oh, we have one response saying right.
Right. Okay. So I guess we're going to go with that response, and I will choose also the right, which is good. Because why we chose the right? Because on the left, yes, I'm sure you're going to have a good plan, but for this lung case, why putting this beam going through the whole contralateral side, going to tissue through the contralateral lung when we're trying to spare this lung as much as possible, when you can choose beams on the ipsilateral side? Even like, look here, we have only 4 fields. Maybe you can add a 5th field here if you want to, but they're all on the left side, and I'm sure you're going to get a good and decent plan. So that's something that you're going to be thinking about, okay? So also the optimization process is very important, and we made that very clear when we discussed this on the topic 17 on December 14. So remember that we gave a lot of tips of which structures we need and how to start playing with lowers and uppers and the weightings. Remember, we said we always start with the PTVs, uppers and lower dose constraints, and the weightings. people call it priorities or penalty. Also with the rings, they are very useful to control the spillage outside the PTVs. And then we were adding the ORs, mean those one by one, to make sure we were not ruining the coverage that we get at the very beginning or at the very beginning of the process. So, and if you were using these, remember, dummy structures that we said, okay, just to control little zones of, spillage or hotspots, just be very careful, because you might be using that structures and then doing something else somewhere else. So with the definition of the structures that we said, PTVs, ORs, and the rings, you will be able to get a decent plan without the use of this dummy, but you can use them too, but just be careful how you use them. So again, we're saying that to get what is a good plan, you need to have good contours and think about it, good beam arrangement, just to make sure that it makes sense, and also the optimization progress is important. So that will answer our question of what is a good plan then, because it's not only just to make sure that you have good target coverage and you just have met all the constraints for the ORs, but it's also a little beyond. You need to make sure how the overall coverage makes sense. If I'm applying the ALARA principle, which is as low as reasonable achievable for the structures that you can, because you never know, the patient might come back. So the lower the dose you give to certain structures, the better. And then that will give you the good answer if it's a good plan. For example, I have two examples here. Like, for example, on the left, there is the 100% isodose line. It's not very conformal, so I can see that this is not a good plan. And also the low isodose lines, 50% spills, outside the body, more than in this is the same patient, the same, we, tweak a plan a little more. And the 100% looks more conformal to the PTV, so you still have good coverage, but there is very conformality on the low doses. See, the 50% are a little bit spilling here. So again, these are things that you need to think on the bigger scale. And of course, I'm just looking at one axial slice here. You need to do the same exercise for the whole extent of the PTV in all the planes. Also, for example, there is these two plans. So both plans, we met all the constraints. This is a prostate case. We met all the constraints for the ORs and the target coverage. So both, they can go for treatment. But but then we start thinking, okay, here in the plan in the left, the 50% isodose line completely encompasses the rectum. So see, the rectum is completely covered by that 50%, even 70% actually is, treating a lot of, encompassing the whole of the rectum. So we tweaked a little more, and we saw, look, the 100% looks very good still, no much different. We meet the constraint, but the rectum dose, basically the isodoses around the rectum, they look better. So you're sparing the rectum a little more. And why we do this? Even though with this plan on the left, we met all the constraints for the rectum, this looks better because you know that this could be, it can be changed every day. So basically you're allowing, okay, I want to give less dose of the minimal of the as low as possible dose to the rectum, because I know this is going to change, it's going to move every day. So why giving more dose when you can give a good plan, sparing the rectum more? And the same applies for other structures. So, but this is just an example. So the plan in the right, I would think is the better plan. Both are good, but the one in the right is the better one. So now we're going to go through, we're talking about, okay, we are expecting to meet the target coverage and to expect to meet all the OR dose evaluation criteria that we might have. So I'm going to go quickly through these general evaluation criteria for both target coverage and OR's dose criteria. So as we all know, for 3D plans, 3D CRT plans, it is very suitable to prescribe those to a point. That's what we normally do when we do a 3D plan or just an APPA or something. We prescribe the dose to a point. Just because the dose distribution in and around the tumor are relatively uniform. That's why we can do that. If the dose is known, we know that if we know the dose in one point, we can easily know the dose in all the other points because we're using uniform beams to treat the patient. So the ICRU reports, you might be familiar with them, they specify that this point, the prescription point, should be in a region where the dose can be calculated accurately and in a central part of the PTV. Most of the time, it's gonna be the isocenter where the beams intersect, and then there is a reason for that point to be somewhere else. For example, if you're blocking and the block is very close to the isocenter for whatever reason, you're gonna choose another point, of course. And we all know that, but it's very easy to do the prescription to a prescription point. As you can see here, I was talking about ICRU report 83, which is the latest, but the original ICRU report that has all how to prescribe, record, and report photon therapy, beam therapy, is the famous ICRU 50, which was done in 1993. Then in 1999, there was a supplement to this. It wasn't a replacement, it was a supplement because, you know, techniques improve, and actually 99, it was, at least in the United States, when we were already using IMRT, so they needed to, you know, update this document, the ICRU 50, and they created the ICRU 63. And finally, in 2010, the ICRU 83, basically they made it more specific for modulated radiation therapy because this was widely used at the time. So they have the need to update it. So they're all good reports. It's not that they all cancel each other. They all have, you still can use ICRU 50 for the regular type of plan, but make sure that you are aware of the latest updates or supplements. For IMRT plans, the situation is a little different because now your dose distribution, they can be more heterogeneous because you know that we're using intensity modulated, so it's very, very, very normal that you're gonna find hot spots within the tumor and hot areas and cold areas, so there's gonna be a little more heterogeneous. So if the prescription point is in a hot region, for example, if you decide to prescribe the dose to a hot region, so the overall dose in the plan will be lower. Conversely, if the prescription point is in the cold region, so the overall dose will be higher. So now the idea of prescribing to a point, it doesn't work anymore for IMRT. So the ICRU report 83 advocates for using a dose volume prescription and not a dose point, meaning that you're going to be using like an isodose to look or a dose volume. For example, we have talked a lot before, most of the, and again, this can vary between institutions, but most of the centers that will normally prescribe or normalize for the PTV in such a thing that the D95 of the PTV is equal or close to 100%, and the CTV D100 is equal or close to 100%. So basically, that's what we've been following in our lectures too. So that's what, but again, these are things that you need to discuss within your institution because different institutions, they might have a little different constraint, but actually this is normally what we all do in terms of target coverage. So this report also advocates that the PTV D50% is a value best be at least reported. They should be reported because this value is relatively reproducible across system and plan. So the D95 can be a little bit different between it, but the D50 of the PTV is a value that is very reproducible across different treatment plan systems and different plans. So that's something, again, I don't know if everybody does it within your institution, probably not, but if you share data, if you share or you share study with others, sometimes this is a good indicator. But it's very important to make sure that you keep consistent within your institution the way that you prescribe. And remember, for IMRT plans, we are not using points anymore, we're using dose volumes prescriptions. For the ORs, those evaluation criteria, I basically refer, every institution, you can develop your own criteria, of course, with a lot of publish data or clinical trials and experience and all that, or share data with other institutions. But they're documents, and that basically they have the minimal, or they have the most important, those criteria to follow. So one of the biggest document, it was the Quantec document, which is the quantitative analysis of normal tissue effects in the clinic. That's, a lot of people follow that because they have a very, this was basically an update and a refine, basically version of the normal tissue dose volume tolerance guideline provided by the classics and Amino paper. We all know that paper, that it was published in 1991. Here's the reference that summarized a lot of the normal tissue dose volume tolerance, but it was too old. So basically this Quantec document, they basically updated that and refined that paper. That paper is still very valid, but this is, again, this is a little more refined. This document summarizes the currently available three-dimensional dose volume outcome data in a clinically useful manner. That's very important to know, that everything is based on dose volume and outcomes too. The information provided by Quantec is not ideal, and care must be taken to apply correctly in the clinic. As I said before, every time that you apply or that you use constraint, you need to be met. You need to make decisions as a global within the radiation oncologists, physicists, everybody who is involved in the treatment of a patient, other institution experience too. But you need to be very careful how you apply, because certain things, they might not be okay, depending what you're doing. So the document, here's a copy of the first page. This was published in the International Journal Radiation Oncology, Biology and Physics in 2010. And it was an effort between different physicists and physicians across the United States from different institutions. So basically, they all gathered a lot of data, and they come out with these tables. They can be I just put the tables here. You can find the document, of course, and there is a lot of more information in the document, how they got the data. But I just wanted to focus how this document looks. For example, if you look at the spinal cord, it tells you, okay, this is a partial, it's a partial organ, because we only care about the area where it's a max dose, and we only care about the area where the PTV is located. So because it's the maximum dose, it's volume constraint. So basically it depends, okay, which technique are you using, 3D or SRS, hyperfractionated. This is the side effect. The myelopathy is if you exceed the doses, what's going to happen with that organ. And then here you have the doses. So the Dmax, for example, has to be less than 55, or between 55 and 60, more than 60. And then you need to make sure, it's here, 50, 60, and 69 is depending on what type of treatment you're doing. And then these are some criteria for single fractions or hyperfractionated cases. This, if the cross section is if you're thinking about three fractions for the hyperfractionated. So basically, you need to be careful how to use it. And again, these can be updated, or they can be basically complemented with your institution own data or the share. For example, for the parodics, here they recommend a mean dose of 25, but we know that globally we use 26. But again, some institutions can be a little more strict. Actually, for example, in our institution, we go way lower than this in general, depending what type of the area of the head and neck are you treating. But again, these are from experiences too. So basically, the table goes on, and you have a lot of organs, most of them are the lungs, esophagus, heart, the most important organs, bowels, rectum, bladder. And there is some very important explanation here when this, how you can apply that. And the most important is it tells you what is the grade toxicity that the endpoint that you can get if you exceed those limits, okay? So again, I just wanted to include you here because this is a good starting point, and I'm sure all of you in your institution, you already have those criteria for ORs. So this is also a good document, and most probably you get it from here, from your own country discussions, but this is a good starting point. As I said before, institution can develop a constraint based on the published data, clinical trial and toxicity reported data. For example, like at MSK, and again, this is just an example. We have a huge spreadsheet, and it's automated with the treatment planning system just to evaluate the doses for each treatment site that you're doing. So that we have, for example, for each anatomical site, for example, this is for brains, IMRT conventional cases. These are the PTV target criteria that we normally follow, which remember that we said, okay, T95 has to be 100% at least. It can be a little more if you can achieve it. PTV V95, PTVD maximum, we always like to be between 1 of 5 and 1 of 10%, and there are notes here. And also you can see here in the bottom the normal tissue criteria for example, the core. For a brain conventional, we said our maximum point dose is 50 gray, and that's the limit. So if you have a case that you need to go past that, you talk to the physician and say how high I can go, or you want to compromise coverage. The same for the optic nerves and optic chiasm. And again, this is very institutional dependent. As I put here, this is for MSK, internal use only, do not use it, but you can always share things with other institutions, but do not implement shared constraints without a clinical review and institutional approval. You never do that. I mean, always think about your clinic, think about your country, think about all your consensus meeting that you have, just to make sure that we are all in the same page. And this is a very dynamic document because this is an example that I put, but we have a lot of different worksheets for different anatomical sites. And as you can see, we actually keep updating this document very often because sometimes we tweak it a little bit. So make sure that that's also well documented when you keep documents. When was the last modification? And then you should have a record of the updates, what was modified, just to keep records of if you need to come back to something. Okay, so any questions so far? If not, again, like we always said, we can always go through questions at the very end. So we can continue.
Yeah,
yes,
I'm not seeing any. Sorry, I was just saying I'm not seeing any in the chat right now, but anyone feel free to add any, or we can wait until the end, whatever you guys prefer.
Yes, awesome. Thank you so much. Yes, thank you for keeping records. I don't know, for some reason I cannot see the chat anymore. I see the participants, but that's okay. You are here.
Yeah, I've got my eyes on it. I think it might be a full screen situation, but
yes, exactly. Yes. Okay, I think I was able to get it. Let's see.
Okay.
Perfect. So now we're going to be moving to the next point, to the next item in our outline, which is what happened to the optimization problem. How do we know when we have pushed enough or as hard as possible for a plan to get the best that you can do? And you also need to understand why it works and how it works. Again, we went through a lot of these in the previous talk, specifically when we were going to the optimization process. But I want to, in this part of the presentation, I want to make sure that we basically, capture the most important thing from last topic too. So we learned in this topic how important is to watch for the PTV shoulders, everything that is, after you get a good coverage, you need to keep watching everything that you do, keep watching the shoulder if you're ruining something or if they are over-covering something during the optimization program while you start adding the ORs constraint. For example, this is a little video, hope it works. Just let me know if it doesn't work. Just to, again, I was exaggerating. So I was looking at the left parody and I was decreasing the mean dose a lot. I mean, this is unreal. While looking at the shoulders of the PTV, see, I decrease it, and you can see how these start getting separated from your objectives. So of course I'm doing, I mean, this is not possible. You can tell, you can look here how bad the coverage looks, but just to give you an idea that how you can ruin a plan basically, because you think, okay, I can get it lower, but look what you're doing to the PTV. if we, I was changing also, not only I was changing the weights of the weighting, and you can see how these two, the PTV 5412 and the PTV 6996, they are basically, you ruin them by lowering the left parotid too much. So you can see. Of course, you can see here that you're ruining the coverage, but if you don't have this image, if you're just working with the with the DVH, which we talked a lot last time, so you can see here very clear that that's not a good idea. So in this case, both parotids were pushed enough right before when we started the video. I tried to push it more because I thought that I could spare more, but I ruined the coverage. So you need to keep watching that. So we also learned in the topic 17, how important is to watch the PTV shoulders during the optimization while you change the ring constraint. Remember, the rings are these structures that they are around the PTV just to control the ISO. This is how nice these 50% ISO dose look like. So just to control the doses outside the PTV. Also, remember, we use the NTO, but this actually makes it a little nicer and conformal. So this is a little video that I was playing. I mean, again, I was exaggerating. See, you can tell I was changing the max, the lower limits by a lot, and you can tell how of course, this is not, you won't be doing that, how bad the PTV coverage looks. So I was changing the maximums, and then I was changing the penalties a lot, or the weightings. So you can see how this PTV 5412, which is the one next to the run, is suffering a lot from what I'm doing. So again, watch the PTV shoulder when you change structures. And then you need to find a balance. Basically, okay, this is the best I could do until I start seeing changes on my PTV shoulder. So, and then you stop right there. Then you might tweak it a little bit here and there because you might need to, improve the PTV coverage eventually later. And you can see on the images on the right, if you have it in your treatment planning system, how, I can easily see here how the 5412 ISO dose doesn't cover well anymore. And just because it's the rind, I was playing too much badly with this ring, which is close to the PTV 5412. I was thinking, oh, I'm going to get a better 50%, but I ruined the coverage. Then lastly, we also learned how important it is to watch the OR DVH using these anchor objectives while you're in the process, when you're trying to improve the PTV coverage. This is the other way around. Now I got a plan, I got all my ORs to the values that I wanted, but is my PTV coverage the best I can do? And then again, I'm going to play the video again. Remember that we put these anchors, or what I'm doing here, I'm just changing the weighting of the PTV 5412 and 6997. And you can see how the parotids, this is the submandibular gland, how it started basically getting ruined. So the DVH is basically passing those anchor points and I wanted to keep them there because that was giving me a good OR sparing, but I'm ruining it because I'm trying to improve as much as possible the OR. See, you can see how this submandibular is very close to these two, and then you can see here how they've been ruined. So basically here, again, I'm over covering the PTV. So that was unnecessary. You had a good coverage, you leave it there. But again, if you think that the coverage needed to be improved and get it to, then remember that we said that you can move those anchors to allow, because I know that the constraint that I was putting in the submandibular, they were not helping with the coverage in these two structures, but it was good to begin with. So again, these are questions and these are situations that you will be asking yourself while you're optimizing how, and then you're going to be answering the question, and if I really push as hard as you can. Remember, for ORs, for rings, and for the PTVs as well, the PTV targets that we use for the optimization. So make sure that you are doing that consciously, and then make sure that you know how it works. That's what is very good. Remember when we explained on the previous session, to go step by step. Don't change everything at the same time, because then you're going to get confused and you don't know what is doing the optimization, what is ruining your plan or what is truly doing. Just start with the PTVs and the rings, get that good, and then start doing the ORs one by one. And then in the later stages of the process, you start refining everything, improving ORs, improving coverage as much as you can. Just by looking at the DVH, how the DVH, because this is going to be very similar to the final DVH. So if you have this picture of the isodose, that's a plus, because then you can easily see how the coverage looks. Okay, and then again, here there is another question, another example of two plans, Plan A and Plan B, for the same, this is the same, done by different planners, if you may. And then Planner A, it says, okay, this is the best plan that I can do, and Planner B, okay, this is the best plan I can do. Which one you think? I mean, this is a plan, it was a left axilla and superclap and axilla target that it was going to 45 gray, and then there was a boost area here going to 5250 SIB. So which one you think, Plan A or Plan B, will be the best plan that you can get? Consider that both planners, they met the constraint, the Plan A or the Plan B. And again, we can use the chat. You don't have to have the right answer, just, okay.
We have a response from Saad Saeed saying A, and then one from Lacter saying B.
B, okay, we have a tie. So we can go with either plan then. Again, both plans are good. Again, another is winning at the moment.
Yeah.
We can go with either plan because both met the target coverage and the ORs constraint. And I can see, we can keep going, but I can see, okay, B, I mean, it's only 2 against 1, very little, not too much democracy here, but very good enough, because actually I will personally also go with B. Why? Because in A, you can see how the lungs, yeah, it was spare across, in all these cuts, but you can see how Plan B spared the lungs even more. And the lower isodoses, they were much more conformal to the PTV without ruining the coverage. The coverage was exactly the same for both plans. The ORs were exactly the same, except that for the right lung, sorry, this was the right side, sorry, it's the left, but it's the right PAV area. So the lung, it looks much better. And that's the ALARA concept that we also need to keep in mind. Yes, I met the constraints in the Plan A, that's good. I can stop right there and move to the next patient. But I say, okay, let me see if I can constrain the lungs a little more, because I know that I'm going to be doing a favor to the patient. The less dose to the lungs, the less side effects and toxicities for later. So without compromising the coverage. So Plan B is actually better than Plan A. Again, it can be a little, subjective, but you always achieve for like the best plan in order with the thought that having the best target coverage, the best OR sparing, the ALARA concept in mind for the ORs. What is the best I can do? One thing with the ALARA that I want to make sure, or the best coverage you can do, and I think you have talks about this, make sure that, okay, now we're conforming the doses so tight to the PTV. So this goes hand in hand with a good immobilization system and a good image guided system that you do during treatment. Why? And I'm sure you learn that with IMRT, because where the isodoses are much more conformal to 3D, you need to make sure that the patient is positioned correctly, and we are accounting for every organ motion, or in this case, breathing motion. So I'm sure you have classes on that, on sessions, and you went through that. So that's very important too. So because then doing an IMRT plan, yes, it's going to look amazing on paper. Look how beautiful the 100% looks here, covers and everything. But if the patient moves, or if the patient is not well immobilized, or we didn't take care of the motion management, it doesn't matter how perfect you get the plan. That perfected 100% dose is not going to go every day to the target that I want. So you make sure that that's very important too. Everything goes together here. Everything is related. Okay, so basically now I have a couple of examples and to show, And then we're gonna be moving to, we're good with time, no? Yes. The examples I'm gonna do, I have, again, these are some examples that you, these examples are gonna be basically, again, some examples that we did. And again, these are plans that I think they're very good, but you can have different opinions too. This is a brain case. It's a right temporal GBM. The prescription is 200 times 30. And you can see here how the PTV overlaps with brainstem, optic chiasm, optic nerve, the right optic nerve, and is very close to the right cochlea. So you can see already, okay, just to begin with, the physician told me to go to 6, wants to go to 6 degree because that's the normal prescription for a GBM. But I know I'm going to have issues, not much with the brainstem, but with the optic structure, because I know that the maximum dose allowable for optic structures is 54 gray. So I know that here I'm going to have issues. So I need to create a plan that allows me to basically spare the dose there. So here I have a little video of the beams that we use. Remember when we did the class about beam arrangement, these are 4 arcs, and this is a coplanar arc. And then there is another coplanar arc. This is a non-coplanar, so 1 coplanar arc and 3 non-coplanar. This is couch 315, then this is couch 270. And again, remember, you choose the best fields to make sure that you help the optimization algorithm to basically get the right plan. Again, you can be very creative with the dose. This is the beam that we chose. But again, remember, for ipsilateral targets, you keep it on the ipsilateral side. This is going to spare everything else. Make sure the clearance is okay. And then after choosing this beam arrangement, we were able to get this plan. As you can see, the 6,000 ISO dose encompasses very well everything except is basically scooping out the optic nerves, because I know that the maximum dose has to be 54, and also the Dmax of the brainstem has to be 60. So we will look at that in a minute. So of course, I mean, if you think that, I say, oh, the 100% doesn't cover the cover, but the whole PTV. But I want to make sure that I'm covering as much as you can, meeting or sparing the ORs that I need to spare. So if we look at the DVH, this is a summary of the DVH. Now it gives me the goals and the limits. It compares the results of your plan, and basically everything green means that it was achieved. Everything orange is because it's more than the goal, but it's less than the limit if there is a limit. So that's okay too. I mean, you have a talk with the physician, but we will never, if it's anything exceeding the limit, it will be red. That's something, it's a bigger discussion. Again, this is something that we develop in our institution. You can manually do the evaluation with your tables too. So you can see here that, for example, optic nerve right, I was right there, 54 grays, so it's 53.37. The chiasm is also met, 53.35. The brainstem, for example, the Dmax, we have if the PTV overlap with the brainstem, we allow the Dmax to go to 60 and the D5% be less than 60. So basically we met the limit. So see, we went over the goals. These are the goals, but we met the limit. Now that's a conversation you need to have the physician. Do you want me to meet the goals, or can I go to the limits just to improve more coverage? The second example that I have here is a lung case. It's a right non-small cell lung carcinoma of the right upper lobe with mediastinal right hilar and right paratracheal adenopathy. So this patient has concurrent chemo. The prescription is 230. We did some motion management. Basically, this simulation was done with 4DCT. I'm not going to go in detail because I think you have had classes on that. The PTV, you can see that overlaps with the esophagus and the heart, of course, and of course the lung, the right lung, and the core and the brachioplexus. They're very close to the PTV. So again, quickly here, I'm going to go to this was an IMRT plans. You can see there is this posterior field, gantry 180, then there is the RPO field, gantry 245. So again, I'm following kind of here the K-shape. You want to be on the lateral side. This is actually because of the limitation of our machine, we needed to split this field. This is kind of 340, but we split it because remember we talked that when you can see that on the videos, actually the tutorial video, depending on your machines. And the last field is an LAO, 20 degrees, and you can see how, they play. So basically we have these 4 fields beam arrangement. And then here you have the plan. So basically, because again, for a lung, you're trying to spare the lungs as much as possible, the distribution is going to be a little kind of like an APPA distribution, but the 100% is very conformal to the PTVs. And of course, you're going to have spillage. So this is, for lung cases, this is 70% isodose. You're going to have that because in order to meet the constraint to the lungs, you need to, there is no way that you're not going to have those spilling, but that's okay, as long as you don't have those here and here. That's what when we said before, adding a beam on the contralateral side is not a good idea because I'm going to make maybe you're going to improve a little bit the distribution, but you're gonna confuse the optimizer. So if we look at at this DVH summary, we have met all the constraints. The brachial plexus, see the right one, which was the problem. It was very close, so it's below 65, which is what we use. Again, these constraints, our constraints. The core, we have a goal of 45, but you can go up to 50, so we are in between, which is good. And the lungs, that was the biggest thing. The V20 has to be less than 37 as a goal, 40, and then here was 30.5. Most probably the physicians, they keep it as low as possible, and we always achieve for 30% instead of 37. But again, you have to have a conversation with the physician. The last example that I have here is with the prescription. Again, I don't know if you follow this prescription. This is a hypofractionated, moderately hypofractionated RT that we do to 70 times 26 to the prostate itself, to 70/20. I don't know, sometimes a lot of people use the conventional 180 times 45 or 42, depending what it is. And then full bladder, we use full bladder for all these patients for treatment every fraction. So you can see for this prostate how the PTV overlap. Of course, it's going to overlap with the rectum. Of course, it's going to be, with the rectum, which is the blue. Of course, it's going to be overlapping with the bladder. This structure here, again, this is something that we do here. This is a spacer that we put between the prostate and the PTV. Again, this is when you do hypofractionated cases, you need it. For conventional, you don't need that. So we do it for some hyperfractionated cases. But the point here is just to, okay, how can I do a plan, the best plan that I can do to achieve the best? And then the beam arrangement that we normally use for these cases is going to be 2 fields, 2 full arcs, because the tumor is very centrally located. So you can see that you can easily get a good plan with 2 arcs, one clockwise and counterclockwise using BMAT. And then that's going to be enough for this case. And then you can see how the distribution looks here. You can see how remember that I was telling, we like in our institution to see the 50% basically sparing the rectum as much as possible, not encompassing too much rectum here. Even we were able to do the 30% in some slices, but not everything. Maybe up here was more difficult. But you can see how nicely the rectum is spared by the isodosis, while the 100% looks very nice and tied to the PTV. And then again, here we have the summary, again, with our constraints for this type of fractionation. And basically the main thing, the rectum is one of the most important structure here. The max dose, we met the max dose, which is we normally go to the limit or close to the limit. This D52 is the goal, so it's a guideline. So we're always close, but sometimes if it's exceeded, you tell the physician, look, I'm going a little over, but I don't want to ruin the coverage. And then everything else for the bladder and so on. Bowel, if it's present or not. So basically, that's it. These are the examples that I have. Do you have any question before I go to the last? I have a message to give you. Again, as you know, you're going to have these lectures recorded, so you can watch it again. And if you have further questions, you're more than welcome to email me directly. and we can go through that. So thank you, because some of you, they have mailed me, for the previous, which is good. So it creates a good communication channel between us. So I'm very happy to answer anything. If you don't have any question right now, you can send me an email. Okay. So the last thing, again, if you have any questions, just post it in the chats. The last thing that I want to remember this, we talked about this in the previous, but I just want to make sure that it's clear for everybody, is about this planning challenge that we're inviting you to participate and to make efforts to create 2 plans for us with the data that we provided. Remember, we said it's going to be a pelvis scale with parabolic nodes and a head and neck. So Benjamin and the people from Rayos Control Cancer have already uploaded the CT scan and the RT structure for these 2 cases. And this is the how you go to, is in Prono. And everything you can view it and download it they're in this workspace, IMRT 2.0 for download. And I'm sure you might be using it already, but if you don't, here's a couple of pictures of, you go to that folder, and then here are the 2 cases. You double click on the case and it will open. This is the head and neck. And then you go to actions and you say download, and it will prompt you to download it, to download the files. And then you can upload it to your treatment planning system, do the plans, and then upload it again. So basically, I'm also here giving you the guidelines for each case. This is the case number 1. The pelvis and parodic with 5 SIVs. Remember to plan this following the VMAT planning guidelines that we went over, topic 16 for contours and topic 17 for the optimization. Remember that I told you that we created this planning tutorial video for this same case as a reference. So you have there how we created the plan and we went through the optimization. This is a great resource. Just watch it while you're planning, or watch it after, before you plan it, whatever, but it's very useful for you. And also review the topic 16 and 17 also. And then here is the prescriptions that we want for this case. We have 3 PTVs, PTV 45, 50, and 55 with the doses each, 25 fractions. These are all simultaneous boosts. And then we also have GTVs that they're going to a higher dose. So this is also a guideline. And I sent you all an email last night. Well, last night for me, probably you get it today early in your time, with more specification. And this is the planning, this is what I included. This is the planning guidelines for your cases, for this case. And then for the head and neck case, which has 3 SIVs. So again, you're gonna follow the VMAT planning guidelines. You have the tutorial video number 2, which we went through the exact process of planning this case with these specifications. And then here, the prescription, you have 3 dose levels simultaneous with simultaneous boost. And this is the planning guidelines. And also here we added that we want to focus mainly on the parotid mean dose be equal or less than 26, and the shoulders and expansion. Remember, if you look at the video, it will be very well explained there how we avoid the shoulder. We talk a little bit about that on the last topic. We want that to be as low as possible, okay? That's mean dose, less than 1.5 there. I'm gonna add that there. So again, thank you very much for your attention. And if you have any question, yes, here is my email. I mean, there is something on the chat.
Yeah,
yes.
About sharing emails.
Yes.
That's fine. I can share mine too to forward them along.
I'm going to write it in the chat in case anyone. That's my email. And again, all these talks and everything, they're going to be uploaded in the RCC. I think it's a Google Drive or the RCC website. You know better, but you all have access. So very important, just to recommend, just go through these. Remember that we gave you this document, the VMAT planning guidelines, is things that we discussed in topic 16 and 17, and also watch the tutorial video, number 1 and number 2, 1 for pelvis, 2 for head and neck. Okay, and good luck. So basically, because our next session is going to be January 5th, and that's the last one we're going to have. Hopefully, I mean, I know the holidays are in between. We don't want to pressure, but if you have a plan by then, that session we're going to dedicated to review these plans. So you can show us what you did, or you can tell us before that you did. We will review it and give you comments in that session. We'll send you updates on that. But if you need more time, don't worry about it, because we will be available to review those cases afterwards and then give a feedback, or maybe create a session, special session to go through questions and answers. Okay. All right. Anything else?
Thank you so much for having this session. And again, if anyone has any questions, we'll be monitoring the chat, and you can, of course, send emails at any point.
Excellent. Thank you so much. Thank you, everybody, for your attention. Happy holidays to everybody, and we'll see you in 2021 again.
Happy holidays and Happy New Year, everyone.
Yes, Happy New Year. Bye-bye.